Welcome to 988 Crisis Lifeline. What to know about the National Hotline. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague Jeff Bornstein. Thank you to our partner for today's event, the National Overdose Prevention Network, a program of the PHI Center for Health Leadership and Impact. Now let's meet the moderator of today's event, Amy Max. Amy is the Senior Program Manager at the PHI Center for Health Leadership and Impact, where she oversees the design, strategy, and continuous quality improvement of multiple public health programs and initiatives. She currently manages operations for CHLI's overdose prevention portfolio, including an annual accelerator program for local overdose coalitions and the National Overdose Prevention Network, which provides training, resources, and learning opportunities to more than 6,000 leaders nationwide. Welcome, Amy.
Thank you so much, Marlene, and thank you everyone for joining today's webinar on the 988 National Crisis Lifeline. Let's go to our agenda for today. We'll start off with a couple of poll questions just to better understand who is in our audience across the country. And then we'll continue with the main presentation, followed by Q&A with our speaker. As always, please use the Q&A feature to reach out with questions that you may have. And you can also use the emoji features in Zoom to share your reactions during the presentation. So for our objectives for today, we want to provide you with an update on the 988 Mental Health Crisis Hotline now that it has been in operation for 1 year, to discuss the immediate effects of the hotline and then opportunities you have to integrate it into your work in overdose prevention and harm reduction. Brooke comes from a multi-sector background in health, direct impact programming for children, youth, and families, and public education nonprofit work. She's the program director for the Cypress Resilience Project and is deputy director of Faces for the Future Coalition, which are both projects of the Public Health Institute. She is also a certified trainer in trauma-informed systems and practice, and has provided mental health first aid training to thousands of people across the country, including many of you all as members of this National Overdose Prevention Network. So with that, I'm excited to introduce Brooke, and she can take it away with our presentation.
Thank you, Amy. I always feel so much better about myself when you get finished. I'm like, hey, I'm here. Hey, everyone. It's nice to see you again. My name is Brooke. As Amy said, my pronouns are she, her. I'm going to go ahead and start right away just by saying, first and foremost, that this may be activating material for some of us. Sometimes we come to this work with some lived experience or lived experiences. And I definitely always remind folks to please take care of yourself. And I always say, treat yourself like a toddler, right? If you're going to be listening to content that may be activating for you today, think about getting, lots of water, make sure to hydrate, eat food that's healthy for you, put yourself to bed on time, read your favorite nighttime story, like all the different things that you would do if a toddler had had a long day. So take care of yourself, connect to the people who care about you and have your back, because sometimes maybe some of this brings some things up. So I always like to start our conversations in that space. The good news here is that changing what we do matters. So as a trauma-informed systems trainer and specialist, I care very much about knowing that what we do has impact. It's actually going to be effective. And we know that the creation of safe space for brains turns out to be really important. Brains have a lot of neuroplasticity and they can heal from trauma, but they require safe safety in order to do it. And trauma-informed work is ultimately about how do we create safe spaces for people so that that healing can begin. And that's my passion. For those of you who know about ACE scores, I have an 8 of 10. And so it's a personal and professional passion for me to ensure that all of us know what to do and what to say. For someone who may be experiencing trauma, has a trauma background, maybe managing mental health or substance use issues as a result of that. And the good news is that it's actually effective. Like, we know that it matters. So I love to start from that premise, because sometimes it can feel a little overwhelming when we are facing some of these systemic issues. And 988 is no different. As a mental health first aid instructor, we are constantly certifying people in MHFA, and we're always telling them, like, call 988. And so we wanted to learn more about how is it going, what's really happening, what are some of the opportunities, what are some of the issues, the problem areas, still the challenges that we still need to navigate, and how is the system reacting, right? Because the idea of 988 is to create more safe space. It's to create more safety. And so it's a trauma-informed lens. It's a trauma-informed practice. The goals are good. How are we doing a year after its implementation? And so today we're going to find out. It's a little bit of a mixed bag, but I think it's important for us to know where those gaps in service are, or where the challenge areas are, so we can advocate in the work that we do to make sure it's stronger. And when we do that, changing what we do really matters. And that's the good news. So I always get really excited about that. So I don't think I have to spend a lot of time on this slide, because you all probably know this all too well. Mental health is a huge public health crisis in our country, in all of its forms. In fact, the World Health Organization is projecting that mental health is the leading cause of global mortality by the year 2030. Now, when you're young, 6.5, 7 years doesn't seem, it seems far away. When you're old and gray like me, like, that's like tomorrow. And I don't think we're ready for that. I don't think that our systems are prepared for it. I don't think we have the workforce to manage that type of crisis. And so all of the metrics that we're seeing are increasing. And you're seeing things like the Surgeon General, who's coming out with advisories and statements and issues saying, hey, things like social media, we've got to take a look at that. Hey, youth mental health is a crisis. So we know these numbers, and it's important to constantly remind ourselves of them. And so we know that there is a need for an easy to use, a user-friendly way to manage crisis. And that's essentially what 988 was intended to do. Well, why not 911? All of the data is very clear. 911, when it is the only tool in the toolkit, leads to disparities in treatment during mental health crisis. There's a lot that's written in the literature about why that's true. I don't think we have time to debate all of that. I just want it to be very clear that 911 is not our optimal option when dealing with a mental health crisis. We want other tools in the toolkit. When we teach mental health first aid, we're always talking about, I want several options. I want lots of different ways that I can access crisis response for the person I may be supporting. And, we know that in many places, 911 is still really going to be the responder, and we'll talk about that in a minute. But we also know that people are much more likely to, for example, experience excessive force in a mental health crisis. We know that mental health diagnoses means that there's a higher increase of incarceration after that in interaction. And we know that involuntary treatment, meaning a psychiatric hold, can in and of itself often be traumatic for people. So sometimes when we think about the different reasons why people won't call a crisis line or wouldn't call 911, it falls into this category of intergenerational and historical traumatization, and or maybe personal lived experience with having involuntary treatment. Involuntary treatment, again, that's being examined. We'll talk a little bit about that in a moment. But I just think it's important to put into context. There was a lot of advocacy around this data and an urgent sense of we need another option. And so 988 was the country's response to this, not wanting 911 to be the first tool we use. So what does 988 do? Essentially, it bypasses the National Suicide Prevention Hotline. It makes it easier. It's easier to remember. You can teach it to young people. You can do QR codes for it. It's kind of one of those numbers that you stick in the back of your head and you've got it and it's good to go. It directly connects you to a trained crisis management professional on the other end of that line in a local or regional way. So the idea is that you're not calling a national number. Now, the national infrastructure is there if that regional operating panel is full, right? So if you called and there was no, buddy there to answer your call, the call automatically gets bumped to the national level. So there's always a safety net there. And the crisis counselor then can determine if a wellness check is required. And a wellness check then would be a crisis response. So someone coming to make sure that I, Brooke, am safe in this moment. So there's the interaction with the person who's essentially doing intake or assessment. How serious is this situation? How vulnerable is this person? How much danger are they in? And then if it's deemed, okay, talking about this on the phone isn't going to be enough, then there may be a need for a crisis response team to go and check on the person physically in person. Now, a couple of things to sort of put into context there. One is everyone is very concerned, does 988 geolocate, meaning if I call, do they know where I am? Interestingly, the connection that you have to the local or regional responder is actually based on the area code of the phone you're using. So for many of us, that's going to be a cell phone. So the area code of your cell phone number, maybe you had a cell phone in New York and now you live in Texas, right? It actually is connecting you to that crisis counselor in New York where your area code is, not in Texas. And so some people have said, hey, that's really good, because advocates have said we don't want to geolocate based on call. Would that make someone less likely to call because they're afraid of the response? They're afraid 911 would be activated. Maybe there's historical or intergenerational trauma in the community related to that. So some people have said it's a really good thing that 988 doesn't geolocate. Other people have said actually it causes delays, because what has to happen then is someone's got to put you on hold and transfer you to the right locale if they want a local person to do a wellness check. So it may be that I'm in Texas and I'm calling and I get someone in New York, and maybe the conversation is enough, right? But so there are pros and cons about geolocation, and I know are a couple of studies out there that are looking at that specifically. But right now, just so we all know and have a shared mental model about how it operates, 988 uses the area code of the number you're using to call, and that's how you're connected to that resource. The other thing is that 988 is instructed to answer all calls. The goal is to answer everything, right? And so it's really important for us to know that that assessment might be happening very quickly. So imagine there's a high volume of calls. That assessment may be happening very quickly. And if it's determined that that person is not in immediate danger, the decision can be made to have them call back later or to schedule a time when someone else will call them. Now, part of the criticism I've heard from users is you don't get the same counselor each time. Right. So that might be really hard for someone. Let's say I am experiencing a mental health crisis and I call and I connect with you and you say to me, hey, Brooke, there's a high volume of calls today and I am going to schedule a time for someone to call you back. And then a different person calls me back. I've just been through all of this story with one person. How do I feel about a different person calling, right? So there's some issue there. I've also heard anecdotal evidence, people using the system that have said that they have been waiting, right? Someone came on the line and said, hey, like, we are experiencing a high volume of calls. We are going to ask you to wait. But the impetus for that, for the wait, for maybe making another appointment, for calling you back, is that there's this mandate to answer every call and to triage very quickly when volume is high to try to ensure they're getting to as many people and determining what point of crisis is everyone in, how vulnerable is everyone, and then sort of try to meet the need from there. So that's important for people to know. What we know during the first year is that obviously calls have increased. I think that was pretty predictable. We know that I've seen estimates of everything from 14 to 30%. I think it depends on region and how robust the 988 systems are in different regions, like whether or not you're seeing really significant increases. A lot of it may have to do with, resources, like how many resources are there, how many are getting kicked to the national level. But in general, you're seeing an increase in usage. And I think that it makes sense, right? It's an easier tool to use. It's 3 numbers, not 10. Most people, when I was teaching mental health first aid prior to 988, most people didn't know the suicide prevention hotline, right? So it's not like everyone had that number memorized or sitting in their phone. And so it definitely is a tool that I think more people are likely to use because it's easy to remember. So we're seeing this increase in calls. We are also seeing some diversion. So that's another sort of issue, is that calls that typically would have gone to 911 are now being diverted. And that's actually, from some people's perspective, an actual good thing, because it's saving 911 resources and it's not requiring the same amount of bandwidth in the 911 system. And so the diversion from 911 to 988, some people are tracking that as well to say, okay, how many people are still in the practice of calling 911, but they end up getting connected to 988 instead. But in general, it definitely is an increase in use. I actually have a conversation about warm lines in just a second. So I see in the Q&A, there's a question about warm lines. I think warm lines are a really important resource. And I actually have a link for you. These slides will be made available to you, and I've embedded a lot of links in them. If you are interested in any of the resources or material that we're looking at, please go and find the slides, because those links are going going to lead you to different things. And one of them I've got is a search engine for warm lines. So you can be able to look at a warm line platform and determine what warm lines are in your region. And we have found that very helpful during mental health first aid trainings, because not everyone is at crisis, but they still may need someone to talk to, right? And actually, especially for young people, warm lines can be really important. Kristen, so a warm line, we're kind of getting ahead of ourselves a little bit, but that's cool. A warm line is another option for someone who needs to talk to somebody who may be experiencing some mental health challenges, but is not vulnerable, say, to suicide, or is not in immediate danger of hurting themselves or hurting someone else. And so 988 is really designed to be crisis oriented. A warm line is more like, I really need someone to talk to. And they can be very effective. So I'll show you that. Oh, there it is again. It's at the bottom of this slide. So you'll see there's a link to that, that option. So when we call 988, what's the response? So we actually, as a team at Cypress, we called all of the 12 numbers, the regional panels, the call centers across the state of California where we're located, because we wanted to find out, how does this actually work in real life? And we did it kind of secret shopper style, meaning we disclosed to the person right away, this is what we're doing. We have some standardized questions. We want to learn about how you're actually operating. Tell us more about what's going on. If you are curious about that, I know that, for the California folks, if you're interested in seeing that raw data, we'd be happy to share that too. You can always reach out to me or reach out to Nopin and we can give that to you. But we just wanted to get a sense, like, okay, in our state, like, what is this like? What actually happens? The first thing is that you are given selections. So there are these specialized counselors that are available for Spanish speakers, for veterans, and for the LGBTQ plus A plus population, right? So if I self-identify LGBTQA plus, I can press 3 and I get someone who understands maybe my perspective, how maybe some of my lived experience, someone who has special training in helping that population. The same with veterans, right? So you're going to get a 988 crisis counselor who has special training in how to meet the needs of the veteran population. Part of the reason is we see very high rates of death by suicide in veterans and in LGBTQ plus young people in particular, for example. So these are very vulnerable populations. Spanish speaking, that was pretty consistent across California. That makes sense in California. Certainly, we would hope that there would be Spanish speakers there. There was some discrepancy about how many they had on staff or what their capacity was for monolingual Spanish speakers, but it is an option in the drop-down menu. And we were told that if they didn't have that resource in hand, they could send that person to the national council. Now, again, or to the national numbers. Again, that may mean a delay, putting someone on hold and saying, I'm going to transfer you, but it at least would connect to someone speaking Spanish, which is not a bad thing. The other thing is that the assessment is done and then there's a safety plan created. So the concept would be, I'm assessing as a responder, I'm assessing what the level of crisis here is, and I'm helping to create a safety plan with the caller. A safety plan may include things like identifying people in my circle of support whom I trust that I can reach out to if I feel this way again. It may be accessing other resources. Sometimes we were told they will make follow-up calls. So, hey, is it okay if we call you in a day? Is it okay if we call you in 2 days? That was not consistent. And my sense was that it had to do with capacity, but sometimes they are offering, can I check in with you in a day, in 2 days, in 3 days, and make sure that our safety plan is still in place. Again, not consistently, but it did tend to be something that was offered sporadically. Again, my guess anecdotally is that it's based in capacity. The overarching thing that we found also is that the response, the wellness check, I saw that question in the Q&A, the wellness check itself, right? That is a very low percentage of people. Most people that are calling this number feel better talking to somebody, feel better with the safety plan in place, feel better maybe with a follow-up phone call. And it was a very small percentage of people that were actually requiring a wellness check, a physical, like a team to go out and check on the person physically. Now, having said that, there are independent numbers in many, many regions where they already have mobile mental health units. So it may be that the data is slightly skewed because people are just calling a mobile mental health unit directly, right? So it doesn't necessarily mean that there aren't more mobile mental health unit responses. It just means through this particular tool, through this particular number, it's about 2% of the folks require a wellness check. And that response differs greatly by region. And so there was no, I was saying to the team before we started, when we were in the green room, I hate to say this, but one of the consistent things that we realized is that there's no continuity here. There's no standard practice across the state as large as California. There were differences by region. There were differences within the region. Sometimes we would call and they would say, sometimes we handle this, sometimes we handle it this way, sometimes we have to do that. And it was based on capacity. And so it is, it's one of those things that's kind of a mixed bag. Where you don't always know exactly what's there unless and until you know what's in your region, because there was a lot of discrepancy by region. I see the question about the veteran Spanish and LGBTQ A+ folks being rerouted to national. That was true, except in regions where they had capacity. And you're going to hear me say that over and over and over again, because every time we talked to these folks, they were talking about capacity. Again, when we called all 12, they were like, well, it depends, because like we had this person, but then we didn't. And when we had a team, but then, and so it was one of those things where, on the one hand, it was great because that the national line is the backup, but it also sort of defeats this purpose of local and regional response if we don't build capacity in general to manage those subpopulations. So it was a mixed bag, to your point. But yeah, if they don't have those folks on staff, they're moving them to the national centers. And then warm lines, we talked about those a little bit. I do think those can be a helpful tool. It's not for everyone. If someone is in crisis, obviously they have to, have a crisis response. But if someone just needs to talk to somebody and is dealing with a mental health challenge, the other thing about warm lines is many of them are, they're staffed by people with lived experience. So you're seeing a lot of infrastructure going into building up the peer specialist population. So really investing in the workforce with people with lived experience to do things like answer calls on warm lines. So warm lines can be an effective tool that we would want people to know about. And it's interesting to me because I don't think very many people know about them. When I talk to people about warm lines, a lot of times folks are like, oh, I didn't even know that was an option. But for many people, I think it could be a viable option. So what are some of the opportunities or some of the wins, if you will? First of all, we, through the American Rescue Plan Act, that has created some matching funds for Medicaid for the actual mobile response. So if a crisis response is required, someone's in actual danger, someone needs to go and check on them, that has matching funds now through Medicaid. That's really important. And so just that precedent of like, hey, we're actually going to think about ways to pay for this. I've heard a lot of county officials who've said to me, like, that's really helpful because we didn't know, like, we want to build out mobile mental health response units, crisis response units. We don't want 911 to be the option. How in the heck are we going to pay for it? And so that's really important. The other thing is that we've got this interactive map for you that states are beginning to legislate crisis response, meaning there is all different kinds of legislation that's being discussed in different states that has to do with county systems. It has to do with 988 and increasing the workforce necessary. A lot of it has to do with what the crisis response will be. So that mobile mental health unit that goes out and checks on someone. And so again, this hyperlink will show you very specifically. You can scroll over the map, you can look at your state, you can actually also, there's a drop down where you can look at all the different bills that are maybe being debated in your state, that are pending, that are waiting for signature. We found it very helpful as a tool to sort of get a better sense of what's actually going on in the ground state by state. We also know that some states are starting to talk about adding substance use disorder into the language of that legislation. Now, that's really important for this group here. California, again, where we're located, they are utilizing the language of, that this is a mental health and substance use crisis line. Now, that's really cool and that's super important, but there's still complicating factors with that. So part of the issue, for example, is there are no drop downs for substance use. So there are currently not substance use counselors on 988. That's a problem. So do you want to promote it as a substance use crisis hotline and then not have substance use counselors on there? A lot of concern about that. People may need special training in order to answer those calls. There is still the conversation about, is 988 being used for overdose? Like if I call 988, they are not equipped to handle an overdose. So what they tell you to do is hang up and call 911, or they transfer you to 911 directly. So there's still some, how much do we want to promote that without the infrastructure being there? So I think that's an open question, but the states that are at least thinking about adding that means to me that then they will have to back that up with some resources, right? Because they're going to, if they promote it as a substance use crisis hotline, they're going to need substance use counselors on the hotline. So that's something for you all to know, is that some states, it's just mental health crisis hotline, that's it. Suicide prevention, that's it. In other places, they're starting to say, no, we actually need to add substance use in there as well. We also know that there is stronger collaboration in regions because of 988 between 988 and other types of crisis responders, including 911. So I had talked about that diversion. So for example, we looked at LA County. LA had significant cost savings related to the diversion of 911 resources to 988. And so I think that there's been a lot more collaboration and conversation between these different types of response entities and institutions within counties that may allow us to have a more robust system for crisis management moving forward. And it's not perfect. You're hearing me talk a lot about all the different things that are complicated. I keep trying to remind myself, like, hey, it's only a year old. Like, it's really hard to have system change and do this big thing in a year. And these are really important things for us to know about. So a lot of folks are talking about the continuum of care, meaning a person in crisis needs someone to talk to, potentially someone to respond, and then somewhere to go. And there are lots and lots of gaps in that continuum of care. If we've given them someone to talk to, 988, we know that that's not perfect. We're already talking about that. We know that the response they may require, so the actual wellness check, that's going to differ significantly. And in some places, that still means 911 is going to get called. If there are not mobile mental health units in that region, 911 is who they call. So someone to respond may still not be where we want it to be, and then somewhere to go. We are hearing all different kinds of, acute care centers for mental health crisis that are full and can't, like, you can't get in. Some emergency rooms are full and people are spending days, sometimes like 3-4 days in the emergency department waiting for a bed in the psychiatry department. So we know that somewhere to go is a huge issue, and we aren't prepared for the influx and the increase in like the need for crisis intervention and acute care. So that continuum of care is a very, the second you start to talk about one piece of it, it brings up all the other pieces, right? And there are definitely still gaps. We have a workforce problem. We already mentioned it with peer specialists, but we have this work problem. Who's going to do all this? Who's staffing all the crisis call centers? Do we have enough people? I saw earlier, what about culturally relevant folks, right? Like a multilingual, multicultural response workforce is actually pretty important depending on who's calling. Amy mentioned that I help run another program called the FACES program. It's a health career pipeline program for underrepresented young people in high school. So we connect them to internships and different things, and we operate in 4 states. We serve about 1,500 students in high schools a year, and they speak 26 languages. And we're constantly telling them, we need you so desperately because you come from multilingual, multicultural backgrounds, and health systems still don't reflect the populations they serve. So it's not just that we need more numbers. It's who are the numbers that actually matters, because we need that multilingual, multicultural response in order to actually be effective. So it's not just about the number, it's about who's answering the phone. And that's actually really, really important. And it takes a long time to take one of our high school students, one of our FACES students, and turn them into that crisis responder. Takes a long time for them to grow into an LCSW or a prescriber, say a nurse practitioner, psych nurse practitioner. So these are long-term investments that are going to be required in the workforce. So that's a very complicated conversation. But in the meantime, we actually need bodies, people, to answer the call. How does this align with red flag laws? I know that there are studies that are looking at this. Red flag laws are intended to sort of call, sort of like an alarm, if you will, when someone has weapons, access to weapons. And so if we were concerned about them, and again, most of the time, this would be that they themselves are vulnerable to a death by suicide. I want to be really clear. It's about 4% of aggressive behaviors turn violent. And I think that that's a very complicated conversation that we're having about guns and mental health. So I just want to put that out there. Red flag laws are intended to keep people safe. By alerting officials that, hey, this person is in crisis and has access to weapons. How does that interact with 988? Like, I think that's an open question. I haven't seen any data on that. If any of you have it to share, throw it in the Q&A, because I'm super curious about it. Does it increase the likelihood that people are going to call? Does it decrease the likelihood that they're going to call? In some states, the red flag laws can even lead to confiscation of those weapons. And your property is not released to you unless and until you pass a psychiatric assessment and a judge approves. So some of the red flag laws are actually fairly strict. The intention of them is to keep people safe, again, most likely from a death by suicide. And does that impact people's willingness to use 988 or not? I haven't seen data on that yet, but I'm watching because more and more states are interested in enacting red flag laws as a response to the conversation about weapons. And then, as I said, there's not yet that substance use disorder option, right? So we don't have a drop down for substance use, and we don't have those highly trained professionals that we would need to deal with that. And then you have this issue, am I in substance use crisis? Is it an overdose situation? In which case 911 gets called anyway. So how do we educate the community? And this is a really important thing for the work that you all do, right? Like, we want to encourage the use of 988. I think it's important. And there are a couple of caveats that I would say. I think first and foremost, you have to make yourself a student of what's actually in your region. You have to know, what do you have mobile mental health units? Do you not? And I say that because when we teach mental health first aid and we are working with people who want to help be a supporter of someone who may be in crisis, a lot of the first things they'll ask is, well, how does this all work? Because if I set an incorrect expectation, will that person ever trust me again? And I think that's a legitimate concern. And so, setting expectations is critical for building trust and credibility. It's a trauma-informed practice, in fact, to have authenticity, transparency, accountability. Those are in the SAMHSA trauma-informed guidelines, right? Like, so what we're always trying to do is, to the best of our ability, set an appropriate expectation. So, for example, we teach people in mental health first aid, hey, remember 988 doesn't geolocate, but it may connect you to a counselor that is outside of your immediate region because it's using the area code for your cell phone, in which case you may be put on hold. I want a person in crisis to know they may be put on hold. Right. And so you want to set those proper expectations. And the only way you can really do that is to know in your region what is operational and what's not. And then it is important to let people know, sometimes in our region, 911 is still the go-to. That is still the response that someone is going to get. Marla, I see in the Q&A, like, how do you find out? It's very, usually what I'm finding, so again, I wish there was a cleaner answer for you. But the reality is, some mobile mental health units are being run independently, right? So they're their own organization. Some are being run through fire, right? So EMS. Some are county driven, so they're using county dollars. The only way that we've known to really find out for sure is to call county mental health services and say, do you have a resource guide? Can you tell me the mobile mental health numbers? Sometimes it's an independent number, right? Sometimes it's like, oh, if you call this number, you can get a mobile mental health unit. Now, even where they have them, they have capacity issues, right? So even if my region has them, I may still wait for a long time, or I may get a 911 response anyway, even if the mobile mental health unit is an option, because maybe the mobile mental health unit is over here. Some counties we've seen have like two, right? And that's not very robust to meet the need. And so it's a work in progress, but I think in general, what I want us to know, make yourself a student of what is available in your region, understand this is a work in progress, and aren't there so many opportunities for us to advocate, right? And that's my other point on this slide, is that because this isn't perfect, and because it still has very clear and identifiable gaps, there's lots and lots of opportunity for us to advocate in our county and state systems to say, we want 988 to be robust. We want it to be fully funded. We want the continuum of care to make sense. We want investments in workforce. This is a holistic advocacy moment for us. Because I'm just seeing it kind of patchworked together like a quilt. And that's great, sort of, but it's not going to be sustainable. And what it means inherently is there are going to be differences and disparities in care. And so, and that's going to happen by region. And let's be honest, the facts that, are typically are the people who are in lower socioeconomic, the demographics, the folks who live in rural regions, people of color, indigenous people, those are going to be the folks who suffer the most. And so we're just perpetuating historical and systemic trauma if we don't get this continuity of care right. And so I just want to put that out there, that this is a sincere advocacy moment for those of us who want to use 988 as a tool. The other thing just to keep in mind, this is not crisis counseling. It is intended to triage. It's intended to assess, is this person safe? And it's suicide prevention. Primarily when you hear them talk, when we called all those 12, centers, pretty much what they were saying is, we're here to make sure that someone doesn't die by suicide tonight. And so that's really important. This isn't an ongoing thing. So again, it brings up that, where does the person go? Right. So you want to be really clear, and certainly in many of the regions that we work in and serve, there is not easy access to something like a therapist, right? Like, talk about a problem with a multilingual, multicultural workforce. Most of the therapists look like me. They're middle-aged white people, and that's not helpful to deal with the issues of diverse populations. So accessing counseling, accessing that continuum of care, that still remains a huge issue. So you want to set the expectation with people also, this is not counseling. Counseling is different. Counseling is a longer term solution. There are some promising practices. So there are, really robust conversations about increasing the workforce pool with people with lived experience. And I think that is super important. There's a lot of what I'm calling out of the box thinking. I hate that term, but everybody knows what it means. There's a lot of conversation about, like, who else can be at the table, and like, look, we need more people that speak more languages. And so you're seeing investments in the state of California. They're looking at the first certification statewide for peer specialists. That's really important. And so I do think that's good, because the pressure of the need is driving the conversation about the workforce. We don't have enough people to deal with this public health crisis. Residential and healing facilities for assessment. There's an awful lot of conversation going on about, why does the treatment plan, the place that someone goes, why does that have to be re-traumatizing? So you're seeing empath, emergency department designs. You're seeing residential facilities or safe houses as an alternative. You're seeing people who are saying, we still need to do the assessment. We still need maybe to let's say, prescribe a medication or get someone on a treatment plan, but why does it have to be traumatizing while we do that? So I think that's a positive thing. You're definitely seeing more cross-sector collaborations, folks who didn't talk to each other before, who are talking to each other now. That's good. You're also seeing increased resources for mental health first aid certification, crisis intervention training. On my team, I have a colleague, Jasmine, and she always says, everybody is somebody. Right. And so the good thing about mental health first aid certification is that it gets to all the somebodies. There are all sorts of somebodies out there. And inevitably, when we train people, they often come with their professional hat on, but they end up thinking about their niece or their brother or the neighbor they're actually pretty worried about. And so if we're everybody's somebody, to me, continued investment in a safety net of community members who know what to do and know what to say and know how to react in terms of a crisis is absolutely going to save lives. And so I think the mental health first aid movement in this country is actually a real positive. And then, of course, we know workforce, that's going to be top of mind for anybody in a local or region or state. I do want to leave you with some resources and make sure that you have these. So again, ask for the slides and make sure that you're accessing them. There is the National Council for Mental Wellbeing is also hosting another webinar on Monday, July 17. So you can learn even more by registering for that webinar if you're interested. I will say, like, they're pro 988. So just take that for what it's worth. They're going to be pro. They're going to talk to you a lot about increased volume and all the good things it's doing. And that's all true, but they're going to be pro. I also wanted you to know some of the other tools that you might use. So for example, the SAMHSA link there is giving you a lot of educational tools for your community. It's got promotional materials, things you can easily download. That's really important. You can look how there's an infographic about how calls are routed, so that can be helpful to you. I also wanted you to have from Crisis to Care. That's a report that's actually about that continuum of care. So if you wanted to do a deeper dive on thinking through in your region, where are some of those gaps and where might you advocate, you've got a link for that. And then Crisis Now, I just think is a good overall website that discusses sort of crisis response, different best practices and things that are working, challenge areas, opportunities to advocate. So I want to make sure that you have all of those. So I wanted to leave some time for questions. And I also, you always are free to reach out to me by email if that's helpful to you. I saw some questions going through the Q&A. Do we have any of those? Did I miss some? I'm sure I did.
Yes, thanks, Brooke. They are under the answered category. I think they've kind of moved over
okay.
some of them. Let's see, there was one that just came in around organizations. Could organizations connect people to religious organizations like churches nearby that could be closely tied to the individual's religious background as an option if there's a lack of mental health services?
Yeah, so I think actually the faith-based communities are really important. So Mental Health First Aid has a very strong strategy around accessing faith-based communities, and in fact, making sure that faith-based communities have lots of mental health first aid trainers, embedded instructors, things of that nature. So just be assured that the faith community, and by that I mean all faiths, are very much invested in mental health first aid as a strategy. The other thing that I would say, we work with a lot of refugee populations at Cypress. So we've been focused on refugee populations right now in California in the resettlement process from Afghanistan and Ukraine. And so there are differences too in stigma, right? Coming from all different cultures and culture backgrounds, we inherit lots of information about mental health, what it is, and all of that. So we believe very strongly that a trusted messenger is very important in helping someone access, particularly Western mental health. Western mental health services to many people around the world seem like, what is this? You want me to sit down and talk to somebody in this weird room without my family, without my faith leader here? Like, what am I doing? And so we actually think that trusted people embedded in faith-based institutions is really important. Right now, 988, to the best of my knowledge, is not referring people to religious institutions. That doesn't seem to be one of their functions. They're much more interested in whether or not the person is in immediate danger. So I would say probably the best practices that we're seeing have to do with mental health first aid in the faith communities.
Perfect, thank you. And then you touched on this, but I just want to reinforce, because it's come up a couple times, of how folks can find out what's happening in their area. Do they have a response team or not? Kind of what's the setup and infrastructure locally for them?
Yeah, I think again, like it's such a hit or miss thing. And I'm so sorry to have to say that to everybody, because I know that's not a very satisfying answer. The place that I would start is with your county mental health departments and asking them. Typically, county systems will have resource guides already. They've already articulated, these are all the different types of services that we have, and here's what's on the ground. And oftentimes, remember, counties contract with independent organizations as well. So it's not just county funded systems in terms of like their own infrastructure. It can also be community-based organizations. It can be other types of services that they pay to provide services to the community. So they tend to have a resource guide, like this is everything that we are invested in our area, that is meant to be not just about crisis response or a crisis hotline, but also other types of services. So where do I send someone if I think they just need counseling, or maybe they need some grief work, maybe they need to access some substance use counseling, et cetera. So I would start with county mental health departments and take it from there.
Perfect, thank you so much. And if everyone can show their appreciation for Brooke through the emojis. It was just a fantastic overview and presentation. Thank you of everything that's happening with this new system in place. So thank you so much, Brooke, for distilling and breaking it down so clearly for everyone. On our event page, if I can go into the chat, we are posting all the links that were shared in the chat. So you can always go to our event page to get those links, and also we'll post the recording from today and the slides for you to have going forward. So you can go back to that event page, which was just put into the chat, and that's where you'll find everything from today. Our next NOPN webinar on August 22nd will be all around harm reduction opportunities and partnerships with faith-based organizations and communities. So please go ahead and register for that webinar. And with that, I want to thank everyone for joining today. Feel free to contact us with any questions and spread the word of nopn.org. Make sure folks are signed up for our monthly digest to find out about our upcoming webinars and opportunities. Thanks so much, everyone, and big thank you to Brooke.